dyslipidemia and update, diabetic dyslipidemia and update, what a physician must know. So I will take care of the proper timing, and within the time I will try to finish. But the point I would like to emphasize here, uh, before going into the details of slide, diabetes treatment or type 2 diabetes treatment is not just fasting blood sugar and postprandial blood sugar. That's an outdated concept. Diabetes management or type 2 diabetes management means A, B, C, W. Like I will decode this. A for A1C. Goal is less than 7 or less than 6.5. Again, individualized depending on multiple parameters. B is blood pressure. C is cholesterol, and W is weight management. So if we can take care of this A, B, C, W, then our ultimate goal is to prevent the complications of diabetes. Okay. And that's where today's topic, dyslipidemia, is the C. So A, B, C. C is cholesterol. And if we can go into the detail of that cholesterol management, that is dyslipidemia. And I will take you through the latest update and latest guideline that every physician must know. Okay. So few important points, a few important numbers, particularly in the Indian context, as compared to the Western countries. The ASCBD, that is completely differs from the Western countries, the epidemiology part. And it is recognized that Indian developed ASCBD about a decade earlier than Western population. And this is despite having a lower level of LDL. So till now, our main point is the treatment goal is keep the LDL below 70, below 50, below 30. We will go into that. Second is, it is reported that more than 50% of coronary artery disease associated deaths in India occurs below the age of 50. Very, very significant point. So number one killer in diabetes is the myocardial infarction or heart attack. So number one killer is coronary artery disease and the complications. And more than 50% of that coronary artery associated mortality in India occurs below 50 years of age, and 25% of MIs occur below the age of 40. This is a very scary data. 25% of heart attack or myocardial infarctions occur before the age of 40. That is Indian data, and this is the latest from Lipid Association of India and recently published in Journal of Clinical Lipidology. And in the Interheart study, the median age of MI among Indians was 53 years as compared to 58 years in other countries. So what these numbers or this magnitude, it's saying that we need to take care of the cholesterol part very seriously. And according to me, the A, B, C, W in diabetes person, C is number one, B is second, and A is third, and W is taking care. W is interrelated with all the three. So that's where this magnitude or these numbers we need to understand. Okay. Second, what are the risk factors? Now, these ASCBD risk factors, whether diabetes person or not having diabetes, there are different risk factors. There are four major ASCBD risk factors. Major. So these risk factors can be divided into the major risk factors, high risk features, and risk modifiers. We need to understand this and individualize our management plan as per the patient who is in front of us in our OPD or in our hospital. Now, major ASCBD risk factors: age, more than 45 in male, more than 55 in female; cigarette smoking or tobacco use; high blood pressure; and low HDL. These are the four most important major ASCVD risk factors. And then there are 8 different factors which are high risk features, like family history of premature ASCVD, CKD stage 3B or 4, ApoB more than 130, extreme level of single risk factors, lipoprotein small a. This is absolutely a neglected part. We need to be aware as a physician, and we need to make our patients aware that lipoprotein small a, they should check this. This is not under the lipid profile, normal lipid profile. So normal lipid profile, you will see HDL, LDL, VLDL, total cholesterol, triglyceride. And some laboratories, they usually use this term extended lipid profile. They add ApoA, ApoB, and ApoA1. But over that, lipoprotein small a, maybe every 6 months or maybe once in 1 year, we must check lipoprotein small a. So lipoprotein small a more than 50 milligram per deciliter, that is under the high risk feature. Metabolic syndrome, NAFLD, with fibrosis grade 2 or 3. And then CAG score 1 to 99 and 75th percent. And these are high risk features. And there are certain risk modifiers. Okay. lipoprotein small a. So more than 50 or more than equal to 50 is high risk. If your lipoprotein small a is between 20 to 49, this is coming under risk modifiers. Then IGT, impaired fasting glucose, increased waist circumferences, HSCRP more than 2 milligram per liter. This is also another important parameter, inflammatory parameter that we must check maybe once in 6 months or once in 1 year, definitely, and lesser frequency in certain high risk group. If HSCRP is more than 2 milligram per liter, this is also another risk modifier. Plasma triglyceride more than 150 or more than 175 in non-fasting state. Other inflammatory disease conditions like rheumatoid arthritis, psoriasis, spondyloarthropathies, premature menopause, preeclampsia, gestational diabetes, PCOS, all these are risk modifiers. High polygenic risk factor, air pollution, and HIV infection. So air pollution is another important factor. It is one of the risk modifiers for the ASCVD. Then this, according to which parameters, whether it is low risk, moderate risk, high risk, or very high risk. Why this category is important? Because the treatment or the goal in these categories are different. Okay. In this, each individual patient, as a clinician or as a physician, we must divide them into these risk groups and plan our management according to this individualized goal. Now, the point in this slide I would like to emphasize: recurrent ASCVD event despite LDL around 30 milligram per deciliter. This is like important factor. That's extreme risk, category A, B, and then so till now we have been emphasizing on, as a physician, the treatment plan emphasizing on LDL, lowering the LDL. But besides LDL, we also need to take care of the triglyceride and lipoprotein small a. So individual with 30 years or above, if CAC score 0, 1 to 99, 100 to 299, and more than 300. This is according to the Lipid Association of India guideline. Target, the majority of this situation, LDL target high risk group, target is less than 70 milligram per deciliter. Very high risk group, less than 50 milligram per deciliter. And extreme risk group, LDL optional target less than equal to 30 milligram per deciliter. So as low as possible LDL, 70 or less than 70 is the bare minimum, that is in the high risk group. If it is very high risk group, less than 50, extreme high risk group, less than equal to 30. And a recurrent cardiovascular event despite LDL around 30, then myocardial revascularization, aggressive lifestyle management, effective control of all modifiable risk factors. And then what are the molecules or what are the medications that can help? So lifestyle management, definitely a part. Other than that, SGLT2 inhibitor and GLP-1 RA for the metabolic residual risk factor. ICAWH and ethyl if elevated triglyceride, that is the omega-3 part. Colchicine 0.5 milligram per deciliter if HSCRP is more than 2 milligram per deciliter, and DAPT, dual antiplatelet therapy, or aspirin low dose, that is also there. A recurrent cardiovascular event, then consider further lowering of LDL to around 10 to 15 milligram. So this is how higher the risk group, lower is the target of LDL. That is the point I would like to emphasize. But 70, we should remember, less than 70 or close to 50 is what is required in everyone. And this is the target treatment. Low risk group less than 100, moderate risk group less than 70, high risk group 70, then extreme high risk less than 50, less than 30, which are there. But in Indian context, LDL less than 70 is our first target, and close to 50, that will be the optimum. Okay. Non-HDL is a co-primary target and ApoB is the secondary target. So our first primary target is the bad cholesterol, LDL cholesterol. Other than that, non-HDL cholesterol and ApoB, ApoA1, lipoprotein small a, those are the other parameters. But number one, and everyone must remember, LDL, that is the number one target. Lowering LDL will help us in management of ASCVD and prevention of ASCVD. So less than 70, less than 50, less than 30. That is the target. And this is a flow diagram where different risk groups like low risk, moderate risk, high risk, very high risk, extreme high risk. These are the different categories of risk groups. Having classified all this, if you see the lower line, the green and different color codings are there. It is less than 70, moderate. In Indian context, whatever lifestyle we have, and we know at the age of like 10 years before or 1 decade before, we are getting all these ASCVD risk and ASCVD disease conditions. Our target, we should keep our LDL below 70 or close to 50, 50, and that is as per the latest LAI guidelines. If triglyceride, if only hypertriglyceridemia is there, only triglycerides are increased, LDL is maybe less than 70 or close to 50. In that situation, our main lifestyle management, low fat diet, avoid refined carbohydrate, weight reduction, exercise, avoid smoking and alcohol. Other than that, taking care of the secondary causes of hypertriglyceridemia is also important. But in this case, fenofibrate and omega-3, these are the two most important molecules we remember. Obviously, statins are there, HTMFs are there. Those are to be continued, but only for specific hypertriglyceridemia, fibrates and omega-3, and preferably icosapent and ethyl. These are the different molecules that helps us in reducing the LDL levels as well as the triglyceride levels. If there is diabetes mellitus without ASCVD, then if there is no target organ damage or high risk group, LDL, our target should be less than 70. If there is diabetes, LDL less than 70 is our goal. If there is target organ damage already or more than 2 ASCVD risk factors, then LDL target should be less than 50, 50. This is with diabetes. Okay, but if diabetes, this is diabetes and without ASCVD. But if diabetes and ASCVD both are there, then our goal is in extremely high risk group less than 50 and less than 30. So this LDL, most important parameter, LDL, low density lipoprotein. Also in lighter note, it is known as lethally dangerous lipoprotein, LDL. Okay. And if there is acute coronary syndrome, then different groups are there. NAPE patient on low or moderate intensity statin, patients on high intensity statins, and patient with statin intolerance. So these are the 4 categories. In case of statin intolerance, reducing the dose, still re-challenging, that is fine. But still, if it is a confirmed case of statin intolerance, in that situation, low dose statin plus ezetimibe, we can utilize that, or we can try some other statins, or maybe bempedoic acid, or maybe PCSK9. Different options are there. Okay, but the point I would like to remember, or I would like to emphasize for everyone to remember, number one killer in diabetes or without diabetes, it is ASCVD or coronary artery disease or heart attack or myocardial infarction. Now, to take care of that, to prevent that number one killer, we need to take care of that LDL, low density lipoprotein. Other parameters are also there, but if we want to pinpoint one parameter, and what is that parameter? That is LDL. So maintaining LDL level around 70 from an early age is crucial for the prevention of heart disease. This is the most important statement. This is taken from the Lipid Association of India guideline recently published. Everyone should have LDL level around 70 or less than 70, less than 50, less than 30, that is better. Reducing LDL cholesterol by 39 milligram per deciliter at any age lowers the risk of a heart attack by 20% in 5 years, 32% in 12 years, and 53% in next 52 years. And therefore, Lipid Association of India recommends, and I strongly endorse this, lowering LDL at an early age, as it will help in reducing the lifelong risk of major adverse cardiovascular event, that is non-fatal MI, non-fatal stroke, and cardiovascular death. So lowering LDL at an early age is the most important thing that will help in reducing the lifelong risk factors, risk of major ASCVD. So that's all from my side. Thank you. Thank you very much.